This study describes the arthroscopic resection of a non-union inferior pole patella fracture. These are our disclosures. The patient is an 18-year-old male and college baseball pitcher who presented with left anterior inferior knee pain. He had a fall on his anterior knee while in the flex position 8 months prior while in high school, which was initially treated non-operatively with physical therapy. However, symptoms persisted and he complained of anterior knee pain. His physical exam was notable for full range of motion with point tenderness to palpation at the distal patella and positive patellofemoral grind maneuver and straight leg raise test. On X-ray, non-union of the inferior pole of the left patella was noted, with no joint effusion and joint spaces maintained. Magnetic resonance imaging showed the non-union fracture of the distal patella pole with significant edema in Hoffa's fat pad and intact patella tendon. Standard medial and lateral portals were created and diagnostic arthroscopy was performed. We are viewing the left knee from the scope in the lateral portal while the instruments were entered through the medial portal. Debridement of synovitis in the medial, lateral, prepatellar, and infrapatellar fat pad, including the ligamentum mucosum, was performed. The fragment was identified with K-wire drilling, revealing the hypertrophic non-union of the inferior patellar pole with adjacent fat pad edema and overgrowth. After confirming the instability of the fragment, a shaver was used to remove the fibrous non-union tissue between the inferior pole and the rest of the patella. At this point, a radiofrequency device was used to articulate the fragment and distal patella non-union. Careful dissection was done to protect the patella tendon and patella cartilage, and mobilization was performed. The shaver was then switched from the anterior medial to the anterolateral portal as we exposed the gap in the fracture and continued to debride the non-union fragment and fibrotic tissue. The fragment was then liberated with a subperiosteal dissection, and the fragment was removed. Following resection, the patella tendinopathy was debrided to a stable base. The distal aspect of the patella non-union fracture was drilled to promote bone healing and augmented with platelet-rich plasma. Chondroplasty was performed on the distal areas of cartilage involvement, and any lesions were gently smoothed with a shaver. The sclerotic margins were treated with a burr in order to facilitate improved healing. Any final debridement and synovectomy was done, and an intact extensor mechanism was identified. And this is the complete view of the non-union fragment following resection. The patient was recovered via an expedited jumper's knee excision protocol by the senior author. Weeks 0 to 2 post-op included full weight bearing in a braced locked-in extension for all activities with range of motion as tolerated. Then weight bearing and beginning activities without a brace should be achieved around 6 weeks with full range of motion. Weeks 6 to 12 involve a progression to closed chain activities and the addition of more strength exercises and stationary bike. From 12 to 20 weeks, the patient can progress to a more sport-specific drills, running, and jumping after surgeon clearance. Given the lack of open midline split and subsequent repair of the patella tendon, the patient in this case was able to progress as pain allowed and was ultimately cleared to return to baseball without restrictions 14 weeks after surgery with full range of motion and no pain. Although outcomes of arthroscopic non-union resection are not commonly described in the literature, proximal patellar tendinopathy can sometimes cause symptoms similar to this, and that equivalently, good outcomes can be obtained. A retrospective review of 23 patients by Santander et al. Found that an arthroscopically assisted approach for debriding the tendon, bone, and peritoneum significantly reduced pain and allowed most athletes to return to their former activities. Similarly, Lee et al. Demonstrated that arthroscopic decortication of the inferior patellar pole in athletes with refractory chronic patellar tendinopathy led to significant improvements in subjective knee scores and high rates of return to sport. These are our references. Thank you for your time.